Good morning and good afternoon to everyone. My name is Alistair Ager. I'm delighted to welcome you to this skills session. We're going to give people a couple of minutes to join us and hope that you can make yourself comfortable for the next 2 hours. We will be presenting some of our work in the first hour or so, and then we aim to do some participatory work together in the second hour. And I'm asking my colleague Julia just to put on the timetable so you can just judge what's coming up in the next little while, and say make yourself comfortable, hopefully for some useful presentation. So we'll be beginning in about 1 minute. So for those that are just joining us now, welcome, good morning, good afternoon. We're delighted to welcome you to this skills building session with HSR 2020 from colleagues here at Queen Margaret University in Edinburgh and American University in Beirut. And we are running this session as an opportunity to reflect on activities relating to participatory group model building. And so I'm going to just say briefly hello. My name is Alistair Ager. I'm Director of the Institute for Global Health and Development at Queen Margaret University in Edinburgh, and also Director of the NIHR Research Unit on Health in Situations of Fragility. It's great to see so many of you online. We want to run this as a participatory session, as a skills building session where we're sharing our exploration of group model building as a methodology. So we hope to get to know each other over the next couple of hours. So Julia, if you put the screen on, I will make a start and tell us to just take us through a little bit what we'll be doing. So as you can see from that screen, myself and my colleague, can we go back to that's it. Myself and my colleague, Karina Diaconou, will be giving a bit of an introduction, giving a context for our work. Then delighted to have Aya Nubani and Zaina Jamal talk about some case study examples of our work together using group model building as a methodology. We'll have a bit of an opportunity then for general Q&A related to those presentations. We're then going to take a small break in just about an hour's time, and then Karen will be taking us through a participatory exercise to try to really make this a skills building session where we can be reflecting on those methods and sharing together how we might apply them in a very particular context. You'll see there the learning objectives for the session. So we're aware that some of you joining may have very little experience of group model building, and so we want to portray that, describe that in a way that makes it something that's accessible to you, of potential interest and value to you in your work, identifying potential scenarios for its use. But we also want to go a little bit deeper, looking at some of the challenges with it, and also, as we said, give experience of actually implementing a session. And delighted for others who are in the session that might have experience of group model building to share their experience as well. Okay, so I'm ready to make a start now. I hope everyone that's planned to join us is joining us. And thank you, Julia, for flagging that there's a Q&A function. You're very welcome to plant questions there for us to address, either in that Q&A slot, or we might take them briefly after each of the major presentations. It's my pleasurable task just to give a brief introduction to our work in this area, and I use the word exploration in my introductory comments, and want to emphasize that we have been enjoying exploring the application of this methodology of participatory group model building over around the last 5 or 6 years within the group. The figure on the left is a guide that we developed fairly early on to help us develop protocols, and introduces the idea of scripts, which we'll be talking quite a lot about, which are short structures, guides to engaging with groups and eliciting relevant information. That's available on the website for our UHF, our research group, which you can see in the top right-hand corner. And if you search for our UHF at QMU, you'll find that documentation there. We particularly want to talk about group model building as a method that we find is well suited to, and there's just these two phrases that I want to elaborate, developing a systems model representing the forces shaping health system delivery in a specific context. Many of us will work on health systems, and clearly this is a conference very much focused on health systems research. But in trying to understand really a systemic approach to that, we found this a useful model to understand the variety of factors that operate in a systemic way, and developing a model of those factors is hugely useful to us to understand the forces that have shaped the particular behavior of a health system in a particular context at a particular time. But we do this not as casual observers, but usually very much wanting to intervene within that health system and potentially find points of leverage to address health systems functioning. So particularly looking at health systems under particular circumstances and understanding what interventions are likely to produce more adaptive functioning within the health system, and those which are likely to create further difficulties and challenges or have no major effect because of the balancing influence of a variety of factors. The next slide, please, Julia. So I want to introduce this by just presenting a couple of slides, and the key idea of the next couple of slides is just to give you an idea of flow, which we will elaborate in much more detail as we go through. But this diagram starts in the top left-hand corner, works left to right. The top left is, I think we would want each of you to conceive of a context, some aspect of a health system, perhaps some aspect of health systems delivery in which we're interested. And so the top left-hand picture, which is just child health provision in a particular context, is a framing of we're trying to understand the forces that might shape that encounter, both the access to it, the quality of it, the provision of it. And we're interested, if I go to the figures just below it, the graphs, we're interested in the provision of that service or that element of the system's functioning over time. And those graphs just hint to us that these are just two examples of our work, one in Palestine and one in Syria, of either utilization or some other aspect of health service delivery changing over time. And we want to understand the factors that have led to that performance changing over time, to understand the dynamics operating within that system, such that we might be able to predict them and potentially remediate any challenges in terms of that functioning. So we may not always have access to that data in the bottom left-hand corner, but implicitly we're interested in systems where there is change in some important aspect of it, and we're trying to identify what are the factors that are driving that change and what are the consequences of some of those other changes in the system. So to go into the second row of this diagram at the top, to do that, we are then engaging with various stakeholders, and that might include health planners and health workers, health professionals, but it might also quite commonly involve users of health systems. And we're trying through discussions with them to elicit bits of the story, bits of the picture, bits of the understanding of the system as a whole, which they may not experience all elements of it, but they might experience, have insights into operation of some of the key forces in that situation for those key factors. So the post-it note diagram then suggests a process of having elicited information. There's some attempt, like many similar qualitative approaches, to thematically group that, to begin to understand how those experiences shared by multiple stakeholders begin to aggregate into some meaningful variables, some thoughts of some of the key factors that are shaping. And then we go into the third row, where we usually have a team working with a modeling team to try to make sense, not just of clarifying those key factors, but beginning to understand their interrelationship, because it's the interrelationship that's key for a system's understanding. And the figure on the third column at the lower half, where we're doing what's called an interrelationship diagram, we'll talk about that a little later, is beginning to have those people who are experienced within the system begin to understand the relationships between some of the factors that have been identified. Then in the top right-hand corner, we go to a situation through more formal model building and something, either a concept model or a causal loop diagram, which begins to more formally identify what seems to be the major pathways of connection between the variables that have been identified. And we'll describe various forms of developing that sort of modeling and points within it. And then in the bottom right-hand corner, there's an illustration of sometimes going towards a more quantification and a more predictive modeling, which looks at stock and flow diagrams and other forms of analysis. So that's a flow, a typical flow, which over the next hour, 2 hours, we're going to go through that flow 3 or 4 times. Next slide, please. So I just want to give one illustration for some of the earliest work, and I wouldn't do it exactly the same way again, but it's understanding the health system in Yobe State in northern Nigeria during the Boko Haram insurgencies. The Yobe State is the figure, the state shaded in red at the top of the page. Much disruption due to the terrorist activities and anti-insurgents activities, which very much disrupted attendance at health facilities. And one of the particular facilities we were looking at was around safe delivery. And the figure in the top right-hand corner, I hinted at, we're always interested in change, is the dynamics of utilization of health services in 3 LGAs in northern Nigeria during a series of quarters. And you can see rapid fluctuations from no deliveries happening in a particular quarter to a flood of deliveries as people moved from one LGA area to another. So we're interested in that huge change in demand and utilization over time, but we're also interested in understanding the forces that drove that and the consequences of those changes over time. So we had a number of interviews with stakeholders, including clearly women themselves, health providers, health planners, security forces and others. And in the bottom right-hand corner, we're beginning to form the modeling team that's trying to make sense of that. I'll just go on to the next page, please. Thanks, Julia. And this is the fairly primitive model that's developed from that analysis. And if you like, each of these boxes is a post-it note that was refined in terms of discussion. You see in the top right-hand corner, bringing health planners and health providers from Yobe State together. And few of them, if any of them, would have known or experienced every element of this system that was operating in that circumstance. They knew a part of this story, and by bringing them together, we were negotiating how in this particular context, in this particular time, over a period of time, these forces had served to influence each other. And I just wanted to show one example of the sorts of insights then the creation of this sort of diagram could provide for us. So if you give us one click, Julia. So one of the things that this does is to show clearly insecurity was a major driver of the migration of people, created various movement difficulties, which led to a variation in physical access to services, made access to some services easier, to some services less easy, which influenced the utilization of health services. It changed the pressure on health service infrastructure, and sometimes very acutely, sometimes less so, and in that way influenced healthcare quality. So that's a pathway, if you like, through the system that we could understand as a result of the insecurity. The next click, please, Julia. But it's not the only pathway. Insecurity also led to general fear and anxiety, exit of service programs, withdrawal from the area because of security, the restrictions in technical support, the loss of health workers, reduction in HR availability and HR capacity. Health worker workload was increased for those that were there, which again, in turn, is a further distinctive, different pathway, but also impacting healthcare quality. And those are pathways of threat, if you like, within the system. I just want to briefly show 3 pathways of response. So the next slide, please do the next click. The red lines here are around the operation of political will within the state, particularly in terms of enabling stronger security, encouraging HR recruitment through a remobilization campaign, and through the creation of a free drug supply program prior to the events, which significantly reduced some of the challenges that were there. Next slide, next click. Another pathway is this purpley one of the community response, encouraging liaison with security in terms of safe ambulance, encouraging shared access to services, and some lobbying of political authorities to improve mortuary services and emergency services, etc. And finally, one more click, which is the orange, you see in the lower half, of staff commitment and motivation, particularly from Indigenous Yubian health workers, being a strong source of very long and flexible duty shifting patterns and strengthening healthcare quality. So that's a very busy diagram, but it's just to give an early impression of the sorts of insights, not only of the factors that were relevant, but how those were causally linked. The next slide, please. So very, very broadly, in terms of the guide, we've grouped that flow through, we sometimes refer to these 4 phases, sometimes it's a bit more elaborate than that. And for each of these phases, there is an activity or what we call a script to assist in some of the thinking and some of the elicitation or some of the modeling at that stage. And we'll see in our presentations a little while later on, illustrations in terms of those areas. I want to hand on to Karen now, who will take us through a little bit of the theoretical background of this work. Thanks, Karen.
Hi, everyone. I hope you can hear me now. My name is Karen Diakonou, and I'm a research fellow at Queen Margaret University working with our colleagues. And I'm going to introduce a little bit of the theory behind group model building to you. So Julia, if you would put up my slides. Next slide, please. So very briefly, group model building is a method really that emerged as a way to tackle messy problems. And the whole point here really was that we acknowledge that people in the world, who we call clients generally, have specific mental models that they use to make decisions. And very much we acknowledge that the way that decisions are made are influenced by constraints, incentives, actual resources that they might have, so what we might call systems hardware, for example, but equally by perceptions that they have of the social world, including motivations, interest, power, and different dynamics, interpersonal dynamics as well. So in that sense, what group model building is trying to do is to help us build a model that captures both of those things realistically. And it's trying to give us a way to systematically go about this process. And the reason we want to be systematic and we want to actually engage in this process is because eventually, like Alistair said, sometimes we want to build quantitative models. And usually, particularly dynamic quantitative models produce non-intuitive results. And if you're familiar, for example, even with health economic modeling, you might be familiar with that typical, there's a black box behind every model idea, in that people, participants, particularly of work in different contexts, might not understand the kind of assumptions that have gone into model building. And so group model building is really that precursor to that quantitative model building, but it doesn't have to end in that. It's just that most times it does. But by itself, it's just a systematic process to get us there. So it's meant to really enhance the buy-in of different people in the modeling process, the results that might be produced, be they qualitative or quantitative, but equally by itself, by engaging in the process, we expect that participants would learn or gain new insights into the system that they're modeling. Next slide, please. So usually when we go about group model building, we go through various stages, and I've tried to break these down really basically, and also trying to point out where, particularly for health policy and systems research, you might ask different types of questions. So the first thing we want to do is really identify the problem that we want to tackle. So what really is the focus that you want your model to have? What problem are you considering? What is the scope of possible solutions? And again, for us, particularly in our field, what we might want to consider are there particular ways or theories that we want to approach a problem, and how might that actually impact our problem identification? Once we've identified a problem, so for example, a problem could be, like Alistair said, how does the system respond to insecurity in a specific place? What we're interested in is setting a boundary, because that's still a very broad question. So again, you might ask yourself, well, what time frame, what location, what other limits might be relevant to set so that we can really restrict the problem? And again, you might at this point really want to consider what is exogenous. What are things that you know that are beyond the control of either your stakeholders, your participants, especially if you're looking to use group model building for intervention development. You would want to really scope out the kind of range of things that you are considering and only work on those. Again, for health policy research, really, you might be thinking, you might focus on a particular level. So for example, health clinic level, community level, equally district level, but also you might focus on a specific time frame. So for example, I've worked in South Africa, we've looked at tuberculosis, and we've taken the time frame from Tugalefare, the outbreak, onward. So again, you might really need to think about that in relation to the problem. Once you've done that, it's very easy usually to identify what we call the client group. So who has something really to tell you about the problem, and equally, who's going to change anything in terms of decision-making or in terms of resource allocation based on the findings of your group model building. Those are usually the people that you would want to bring together in your sessions. Next slide, please. So usually, but it's not a necessity, you might want to do some initial data collection. So let's say you were focused, like I was just saying, on tuberculosis, South Africa in a particular area. You might then want to do or engage in doing some document review. You might want to do some interviews in preparation for a group model building session, some focus groups, just to understand really what has been going on. Again, group model building is done by a team, so a workshop really is manned by a team, but most team members need to have some level, obviously, of knowledge of the problem itself to be able to interact with participants. Once you've done your initial data collection, but equally you don't necessarily need to do that if it's, for example, a new problem, then you might not have any data on it. You really should be structuring your GMB workshop, and you should appoint a modeling team. My colleague Aya will speak, for example, about the different roles that team members play in group model building, and you really need to think about who is best placed to fulfill different roles. So a session in itself has different scripts, and those scripts are activities that we use to structure the session. And what I really recommend is to train your team and plan for contingencies. So train them in each of the activities, but equally plan what happens, for example, if one of your teams suddenly needs to step away and, for example, look after an upset participant, what exactly happens there? How are you going to be running the session? In the workshop itself, which usually lasts anywhere between 1 day to 3 days, it really depends on the complexity of the problem. You're going to focus your participants around the different scripts that you've developed, and you're going to co-produce specific materials. I would recommend that each day that you debrief as a team and you really consider the positionality of your team members and equally the group dynamics that you've observed on that day. It's really important to have an idea of what's happened and be critical and constructive in your thinking, especially if you have multiple days in which you're actually interacting with a group. Next slide, please. So at this point is when you usually, after the group model building session or within it, you create what we call a raw concept model. And really this concept model, if you're doing it on pen and paper, and we'll do it later online, is what we call a boundary object. So it's a negotiated object that depicts people's understanding and of a specific problem. And usually it's very raw in that, for example, there might be errors in it, there might be variables in it, that factors, like Alistair mentioned, that are too complex. Usually we need to refine that and analyze that a little bit further until we develop a causal loop diagram. At this point, especially for health policy and systems research, if you've not already done it, you should be considering how your causal loop diagram relates to existing theory. And again, if you're using, for example, systems dynamics modeling, at this point, you should be considering not just the pathways within your particular model, but the feedback dynamics that exist within it, because those are the ones we need to be able to do quantitative modeling. And once you have your causal loop diagram, some people just stop here, which is absolutely fine, but some people actually go on to then try and abstract from a bigger causal loop diagram into basically a quantitative model with reduced variables, so a reduced number of variables, which could actually be calibrated and parameterized. So at this point, the choice of model is really guided by the analyst. You could be doing stock flow modeling, like what Alistair said, or you could be doing agent-based modeling. It really depends on how you've actually wanted to engage with this problem. My one recommendation would be to engage early on with your stakeholders and your clients to understand, is quantitative modeling something that they expect? And if so, what kind of scenarios really do they expect you to be modeling? So the last point is just that the whole process is very much iterative. So you might think that actually we go through this and we do it once from beginning to end, but actually what you will need to be thinking about is you might be doing 2 or 3 rounds of group model building workshops, depending on whether you've reached, again, like in most qualitative work, saturation really. I think you'll notice very quickly at the point where you actually know the problem and you know the dynamics that shape it. And if not, then you'll need to go back to your participant group. Next slide, please. So this is just a slide to summarize why we might want to use it for health policy and systems research. And again, I think we're all aware of the trend of saying that health systems are complex and adaptive systems, but group model building is really a method that tries to capture that on purpose and tries to really get us to be a bit more systematic about how we might inquire about complexity. And obviously methods such as system dynamics modeling, for example, or other types of quantitative modeling that capture dynamics have been used more frequently now. So again, some people might be interested in group model building very much as a precursor to quantitative modeling. So again, GMBs are very much useful for that purpose, particularly the qualitative part, because they help you negotiate a kind of concept model causal loop diagram that is a shared understanding between your participants. And again, if you're using, for example, SDM specifically, which I use most often, then most of the time models can help us identify certain leverage points which might inhibit, for example, intervention or policy implementation, and which, if addressed, we could actually have more successful implementation. And the caveat at the bottom is just remember that group model building is not a way to create a perfect model. We know that all models are wrong. What we want to do is capture more of the complexity which we know exists already within health systems. And I'm going to stop here and hand over to my colleague, Aya. Thank you very much.
Hello, everyone. This is Aya Nobani. I'm the project coordinator at the Global Health Institute, and I have been working with the team at Queen Margaret University, and one of our research projects was using this group model building research method. So building on what Karen just provided, I'll be presenting our research work as a case study to share the practicality of conducting the GMB. First slide, please. So our research work was conducted in Lebanon. As Karen mentioned, there are several approaches to conduct GMB. In our case, we could not have the time to conduct semi-structured interviews in order to build our seed models. So our approach was starting with the GMBs and then backing it up with the semi-structured interviews. Now, the main aim of our study was to examine how community members, including the Lebanese and Syrian refugees, perceive mental health problems, and to identify the factors leading to these mental health problems, including political, economic, and cultural factors. This is one of the aims. The second aim was to examine the dynamics of the health-seeking behaviors adopted by the patient, including the barrier that the patient or the person suffering from a mental health problem might encounter during that pathway. So the next slide, please. We selected 2 different fragile settings in Lebanon. One is Beirut, which is the urban city having the lowest percentage of poverty and hosting lowest percentage of Syrian refugees. And also we selected the Bekaa rural areas having the highest percentage of refugees and also the highest percentage of poverty and in major need to health institutional support. We conducted 4 group model building workshops. We categorized our participants into 2 targeted populations, one the Lebanese and the second the Syrian refugees. We conducted 2 workshops with the Lebanese and 2 with the Syrian refugees, and from each setting, 1 in Beirut and 1 in Bekaa for each category. Now, for each group model building workshop, we recruited a number of participants that range from 8 to 16 participants, and we identified an inclusion criteria for the population. We cared about having a gender and age balanced group, also to have people interested in the mental health topic, or they are caregivers of people suffering from certain mental health problem, or adults and adults above the age of 18. Now, due to the sensitivity of the topic, the group, the GMBs and the participants were grouped into 2 or 3 groups, and they were divided by gender in order to minimize the distress and allow the open discussions, especially when it comes to gender-related violence, violence at the level of the community, and other sensitive topics that might come up during the discussion. Next slide, Julia. Now, how the roles, this table presents how the roles of the research team were divided, and they were divided as follows. So at the beginning, we had a convener. The convener is the person who's usually a more senior person that sets the tone of the workshop, and he opens the workshop, gives a brief introduction about the research, how the activities will be conducted, and the output that is going to come up from this workshop. For each group, we're having a facilitator. The facilitator is the one who helps and facilitates the activities throughout the workshop. He asks and initiates the discussion and give more probes in order to understand the public health problem under study. We also have the modeler to develop and analyze the model and then reflect back model-based insights to the participants. We also have on each table, or for each group, the recorder or the note taker in order to capture all of the discussions and try as much as possible not to miss on any point. We had also the translators, for example, since in our group we had like our colleagues from QMU, we needed someone to translate in order for them to understand deeply the discussion that's happening. We also have the observer who just have a look and observe how the dynamics of the workshop are going on and how the overall process is happening. And also the closer or the debriefer is usually the person who opened the discussion, the workshop, and he gives like a wrap up of what happened throughout the day, summarizing the findings and giving like an overall summary of the day. Now, the choreographer is the person who usually reviews the script and the agenda the day before conducting the workshop. So we had a meeting, a team meeting, where we were trained on the scripts that were going to be conducted the next day, and edits were done. So for the next slide, Julio. Now, coming to the scripts and the activities, now this is the picture of the script. The script is usually divided into 3 main sections. The first section is the rich picture. The rich picture is the first activity where participants are asked several questions, and they are allowed to answer only through drawings and reflect on these drawings. It's somehow an icebreaker and a way for engaging participants and entertaining them. Participants in our case were asked about how a person suffering from mental health problem would look like, and what are the factors that might lead to mental health issues, and what health-seeking pathways they might adopt. So they were answering on all of these questions through certain drawings. At the very beginning, we found participants were finding it a bit awkward to like answer their questions through drawings, but after that, and because of the facilitator, they were encouraged and they were engaged in that activity. For the next slide, the second section is the graphs and the trends. So in this section, participants were asked to draw the graphs and the trend lines for us to determine their perceptions on the change in the prevalence of mental health problems in Lebanon and the change in the awareness. So for me, as a quantitative person, as an epidemiologist, I was not convinced at the very beginning with that activity, but later on, after several discussions with the experts in this method, I was convinced that it's only a qualitative way to understand perceptions of participants toward the burden of mental health problem, and it's not reflecting the real reality and the real numbers. Now, the third section where the most of the work happens. Next slide, please, Julia. This is the section where most of the activity or the work happens. So it's the part where we're building the model, and it consists mainly of 3 stages. The first stage is the variable elicitation, where participants had to brainstorm and answer questions that are somehow related to the first section of the rich pictures. We asked them again on factors affecting mental health and the health-seeking journey. They wrote these variables and these factors on sticky notes. So that was our first section. Now for the second section, the interrelationship diagram, these factors were grouped under different themes. For example, there was the sticky notes that are related to the factors affecting mental health were grouped into a circle. And even there was like subgroups, including, for example, the factors that are only related to war and traumas. These were grouped into circles, and participants were brainstormed on how these variables might link to each other. Now, the third stage was the actual development of the causal loop diagram, where the facilitator prompted the participants to consider how each factor and stressors are linked together or might link to other factors. And for the pathway of the health-seeking behavior also, we were trying to prompt the participants in order to answer as much as possible and to get how they think about the health-seeking journey. After each workshop, we had 2 to 3 models. Now for the next slide. These models were, after each workshop, we had transferred these models as they were described by the participants on a software called Vensim. Models that were developed, we had like around, for this study, we had around like 12 models. These models were cleaned further and they were compared. The whole research team met and compared across the different workshops and across groups. And information from these models were further consolidated into one overarching causal loop diagram. So this is a section of the final model that we have published recently, and each of these zones reflect on a certain theme of the factors causing mental health problems. So for example, for the red zone, it reflects on the interrelationship of factors that are related to the war and traumas. The green ones are more related to socioeconomic stressors, and the ones related in blue, they are more related into the community stressors and the intergenerational traumas. So yes, so for the next slide, overall, as a summary of this whole experience, GMBs was a quick way of collecting data and allowing us to understand the dynamics of a certain public health problem. It also allowed the discussion on participants to openly discuss a socially stigmatized topic. We tried to ask generic questions on mental health in order not to cause pressure for the participants, especially that we're having most of them vulnerable groups and Syrian refugees who lived war traumas and displacements. However, they were enjoying reflecting on their own experiences and to open up about their own experiences. It was a bit intense for the research team as well, due to the long hours of facilitation and discussions, and also due to the sensitivity of the topic. Now, I'm done presenting my case study. I will leave it to my colleague Zena to present her case.
Thanks ever so much. It's Alistair here briefly. Zen, just before you come in, thanks ever so much, Aya, for really interesting presentation of that work. Just encouraging people to post any comments in either the chat or Q&A. And I don't know if there's any very specific questions for Aya. We'd be welcome to take those. Just looking for any hands or anything like this. But otherwise, we will pass on to Zaina and we will just come to a general Q&A after Zaina's presentation. We're aware we've been talking at you for more than half an hour or so. So I can't see any questions immediately. So Zaina, off you go. But then we'll take some Q&A for you and Aya, particularly at the end of your presentation. Thank you.
Hello, everyone. So my name is Zaina Jamal. I'm a PhD candidate at Queen Margaret University. I had the pleasure of working with the team at Queen Margaret University on several projects. including research on the UNRWA health system. And today I'm going to be presenting a study that aimed to analyze the challenges and responses of the health system in the face of the Syria crisis. We have conducted 3 case studies on the UNRWA health system, one in Lebanon and another in Syria. And today's case study that I'm going to be presenting is about the UNRWA health services for Palestine refugees that are displaced in Jordan. Now, the study period that we have considered for this particular case study extended from 2010, which is a pre-Syria crisis, up until 2017. And of course, the health system of interest was that of UNRWA. Next slide, please. Yeah. So we have in Jordan, there are, as you can see, there are 10 different refugee camps. We have selected health centers, 3 health centers, specifically Irbid, Zarqa, and Nuzha. And the selected health centers that were chosen were located both inside and outside the refugee camps, and they were exposed to diverse levels of PRS migration. We've conducted 32 qualitative semi-structured key informant interviews in Jordan, and we purposefully sampled facilities and participants. As you can see, different categories of staff were interviewed: administrative staff, clinical staff, managerial staff, and even members from the community, in order to provide a diverse range of accounts related to the UNRWA service delivery during the period of the Syria conflict. Now, after going through the transcribed interviews over and over again, we captured elements that speaks to the overarching research question, and in this case, the elements of resilience of the UNRWA health system versus the challenges that the UNRWA health system has went through during this period. And in this slide, I just wanted to share some examples of the themes that were generated from the interview data. So responses around medications, around staff capacity, and so on. Next slide, please. Yeah. Now, following the WHO building block approach, we then identified variables. We grouped them under health system hardware and software, and this variable list, as I said, is based on the reflections from the interview data that is going to be used later on. I'm going to be referring to later on during the GMBs. Yes. So what we did was a one-day workshop in Amman. We have invited 21 participants into this group model building workshop, and similar to what we did for the interviews, we had a diverse group attending this workshop, beginning with the UNRWA staff from the headquarters that is based in Jordan, in addition to UNRWA field office staff, managers, area health managers, clinical staff, support and administrative staff at the clinics, and of course, members of the local community associations. Now, similar to what Aya has mentioned, we went through a series of activities during this workshop, and what we did was we started off with the rich picture activity, which is a very good icebreaker at the beginning of the workshop, and it helps the participants to think about the actual question and express them in pictures. So what we did was that we gave the participants a big piece of paper, and we asked them to express their thoughts about what the things that were going on in the clinic or around service delivery prior to the conflict, at the height of the conflict and migration, and after the conflict has stabilized. So they had to draw 3 different time periods and express what was going on in drawings. for these 3 different time periods, and no words were allowed, only graphic display. Now, at this point, the pre-prepared list of variables that I had mentioned earlier was shared with the participants. And what we did, in addition to providing them with the list of variables, we gave them Post-it notes, and we asked them to write as many variables as possible relating to the issues that were discussed earlier in the rich picture development. So participants then, they were asked to contrast and compare different variables. Sometimes they had to merge variables into a single variable. They started to prioritize them, and then they were asked to arrange those variables in circles, and they were requested to draw lines linking variables that they thought they were related. Now, the links that are drawn here are going to form the basis for the development of the concept models later on. The third activity was the reference modes activity, whereby at this point, each group was handed, again, marker pens, and they were asked to develop graphs over time for selected key variables. So considering the same time frame, of course, between 2010 and 2011, for example, they were asked to draw a graph over time regarding the medication supply, for instance, or the PRS migration, the refugee migration into Jordan, and so on. Now, as a research group, before going into the workshop, we had already elaborated a seed model, which is basically, we had, from the variables that were extracted from the interview data, we constructed a seed model, which is based on interview data, that is going to form the basis for the causal loop diagram that is going to be prepared later on by the participants. So this is our own mini diagram, just depicting the dynamics of the health system during this period. Now, again, at this point, the participants, they were instructed to start drawing their own causal loop diagram by referring to the variable lists, to the reference mode. And at this point, we started asking the participants to start linking the variables, and the links here were either links of associations or causative chains. And in many instances, participants would disagree on how the connection is made between different variables. And this is where the one of the research team, who is sort of supervising the work of this group, would start asking for clarification, trying to make the participants reach a certain agreement. Now, in some instances, when the discussion goes on for too long, we had to park this item and give the chance for the participants to continue with another part of the model, and then later on these parked items are discussed with the whole group present in the group model building workshop. Now, the initial concept models from the three groups, they were further compared, and they were consolidated into one overarching causal loop diagram. And this diagram, the one that you see, was cleaned up with feedback from everyone, so that everyone in the group model building agreed on a joint narrative. this is just to give you an illustration of how the different concept models were grouped. So one group, for example, was elaborated a concept model on the HR, the UNRWA policy at the headquarters and how they rolled out the different reforms, how this affected the service delivery, and in the second circle, with this was another concept model on the coordination that was happening within UNRWA and with other stakeholders. So all of these concept models, they were merged together, reflecting the dynamic nature of the health system during that period. Thank you very much.
Thanks ever so much, Zaina. So we're going to go to a time of Q&A now. Harry Coleman has asked a question, which I'll come to in just a minute, but to encourage others to post any questions either in the QA or otherwise raise your hand. We'll try and spot you and come to you. For those of you who can see the Q&A, Harry asked, saying this is very interesting and helpful. And you're right, Harry, we are going to go on to more detail, but to look at how this leads to action rather than just description. So I wanted to come both to Zaina and Aya to comment on that in their particular context of UNRWA and mental health provision and its planning in Lebanon. But just to comment, Harry, I think it's a very pertinent question, and I wanted to share three brief reflections. One, so what, is that a number of people who often don't have a chance to tell their story of understanding of the situation really appreciate that. And I think that is a major consequence of empowerment, sometimes of community leaders or of participants or of clerks in a health facility, that they, as someone who is consulted and is contributing to actually what drives quality or drives utilization. So the inclusion and voice of this method, I think, is interesting and does lead to a so what in terms of people appreciating that. There's a deeper so what, though, I think, in terms then of convening, Zena just said, a joint narrative, and I don't think it's always completely consensual, but that's the purpose of understanding, of moving towards a common account. I mentioned in my introduction that individually no one probably knew the whole story, but can see the fuller picture. And it's quite common in the latter sessions of GMBs for people to for the penny to drop, for people to understand that the thing that they found very difficult or very frustrating, that someone wasn't doing something else that they should do, they could see the constraints of those other actors within the system. So that sense of an appreciation of the interdependence of things in that common narrative. And then thirdly, more concretely, that then enabling people to put in particular concrete actions. So I'll come to Zaina and Aya to give indications of things that have come out of the work they describe. But just to go back to the Nigeria example at the outset, then with people in the room coming up with that model, including health planners, and the realization of the flight of health workers and the sense of insecurity that drove that flight. And although there was a goal to have indigenous Yoruba health workers return to the state, and was actually significant interest to the realization of the introduction of a life insurance scheme, so that if those returning to the state were injured, or as some were fatally injured in the actions resulting from the insurgency, then their families would be safe. And actually seeing that was a pathway to address those human resource concerns, and that was implemented with some success. Aya, let's come to you first. Any reflections of what insights? It's still early days, I know, in Lebanon, but what insights came that you think the mental health provision service team will be able to begin to implement?
Yeah, so one thing I forgot to mention during my presentation is that participants at the end of building the model, they were given the chance to vote for the most fragile points in the model that they find like really major issue that needs to be improved in Lebanon when it comes to the mental health services or the mental health in general. And for example, in our case, social stigma remains one of the major barriers for seeking health or help when it comes to either the accessing the health system in general or seeking care from other sources. And the participants at the same time came up with recommendations and solutions in order to improve that situation. These findings were reported in our manuscripts and reflected to mentioned in a policy or a research brief that was shared with the National Mental Health Program that are already doing in their initiative so many activities in order to work on the mental health in Lebanon. And I think to them that's a reflection and evaluation of what's happening or going on at the moment when it comes to mental health perceptions. So basically the workshop helped us identify challenges that are still present at the time in Lebanon and shared with the ministry in order to work further on these issues.
Thanks ever so much, Aya. I'll come to you in a second, Zena. Just an encouragement for any others to ask any questions or clarification at this stage. And Julia, if there's any questions that you can spot that I can't see, just let me know. Zena, can I come to you? Do you want to put your camera on and reflect? What did UNRWA make of the work that we did with them?
Well, yeah, I mean, this workshop, it helped the participants to start thinking of the different aspects of the health system in a way that they probably haven't thought that they could impact the health system in that manner. So, for instance, one of the things that came out from the workshop that was interesting for the UNRWA staff was the importance of flexibility and the delegation of power to the field offices to act promptly, and so I mean. It definitely drew their attention to different aspects that enabled service delivery during this during the Syria crisis. Yeah.
Thank you, Zena. Aya, did you want to add something or no? Okay, that's fine. Karen, please come in. You're on mute, Karen.
Okay, can you hear me now? Hopefully.
Yes.
I was just saying there's 2 extra questions that have come in, so I'm just going to give those over to you unless you want to have a further comment on this. Yep. Okay, so one question from Lucy Gilson, parallel session on human-centered design, and the question is really about, are there significant differences between group model building and human-centered design? What pros and cons might there be of each? I'm happy to try and take that if you like.
Yeah, please do.
Yeah, so I think, and I'm not very familiar with human-centered design, but I've done some work in technology development, for example, and I think the biggest difference would be, in my view, generally from what I remember human-centered design doing, it's convening groups that are actually quite similar to feed in on one problem at a time, if you like, whereas with group model building, we try to bring everybody in together at the same time. So that's one critical difference, and we try to negotiate a deeper account. Additionally, I would think, especially for health, and I'm quite interested now to listen to the other session, there's something to be said about group model building doesn't presume that, again, it's not about making the product human-centric or about our service necessarily. So, for example, service integration or person-centeredness or, any kind of normative guidance, yes, can guide the way that we do group model building or the kind of end goal of what we want to be achieving with the problem identification and then intervention identification. But it's not necessary. We could be looking at, for example, even just enhancing efficiency within the system. And so there might be very big differences in terms of the kind of theoretical angle that you take to things, and it might not immediately match that of human-centered design. I hope that helps, but I'll be interested to look at that session. There's another question. Sorry, I'm just going through them because there's more coming. How can these methods be integrated in the routine activities of health facilities without a research team behind them? From Daniel Munoz. Anyone want to take that? Alistair, Zena, Aya, or again, I'm happy to try.
Can you repeat the question, Karen? I caught half of it, so I was just checking another question.
Sorry. So the question is, how can these methods, so group model building, for example, be integrated in the routine activities of health facilities? And I have some thoughts if you want, or...
Yeah, no, I'll start with that. I think I want to share an example, a failed example, which I'll slightly anonymize, really, just to show, I think, the challenge that the positive example actually would be UNRWA. That's the one that I probably know best, where it did feel that the activities that we engaged in recognized, validated, profiled a degree of flexibility, particularly our work with UNRWA Syria in a very difficult, challenging situation, and acknowledge the flexibility, the networking, the close supervision, which had been crucial to health systems resilience. And by recognizing it, sort of encouraging its further flourishing, and at a senior level. So there was a sense to which it revealed an organizational quality which could then be celebrated and extended. But I know of another instance which is less favorable, where the work revealed the very complex different views of different bits of the system, and basically the GMB itself was hugely encouraging of suddenly the scales falling from people's eyes. And this was particularly working at across district and provincial and local levels, of recognizing that there was misunderstandings, that there were different models of understanding what was happening, and that negotiating a common model appeared to reveal some of the misunderstandings and some of the knots in the system, if you like, which could be corrected, which when we went back a year later for various discussions had not been corrected. So the revealing of them, of those complexities, and the voice, the provision of the voice for different actors within the system on one occasion for a GMB was not a sufficient condition in that instance for creating a culture of broader reflection within it. So my answer to that question would be, I think it does reveal, and it links a little bit to Lucy's question, doesn't it, of bringing people together to reflect on service design is a good thing, and it crowdsources insights in a potentially useful way. But I wouldn't present it as a panacea to doing that if there are structural barriers and challenges getting in the way of that. Back over to you, Karen. I saw there was a question about stocks and flows. About balancing loops and others, which I don't know if you want to take, Karen, briefly before we take that break.
Yes, no, I mean, I'm happy to. There were examples of both, actually, especially in the UNRWA example, but equally in our work in Lebanon, not necessarily in the model that Aya presented, but...
Sorry, Karen, do you want to explain for those that don't know about balancing and reinforcing loops? Sorry, right, great question.
Sorry, so a feedback loop can be either balancing or reinforcing. As the name might suggest, it's reinforcing is if essentially the impact of one variable drives increases in the next one and the next variable and so on. So the loop in itself, if we leave it out of control, would keep basically reinforcing the same behavior over and over again. In contrast, a balancing one at the end would actually not do that. There might be one variable that counteracts, if you like, the influences of the others. That's basically at the simplest that I could explain it. There were some examples of this. I think the easiest ones most of the time to think about are the ones that relate to human resource management, really, because you can definitely see a lot of reinforcing loops, especially around utilization of services that increases very rapidly, or that then drives workload, that drives in turn of exhaustion of staff, drives absenteeism, in turn actually reduces human resource capacity and eventually leads to higher utilization on some staff members. So again, those are the kind of loops we were able to identify quite quickly, and equally we're able to identify variables that might balance that. So for example, for UNRWA, there were hires that were then made just to be able to balance that out and to create new human resource capacity. I think one thing to just remember is that that actually requires a modeler to look at it. It's very difficult for people to identify those loops by themselves in a group model building session. It might require a little bit more analysis in the meantime. Yep. I think...
Karen, I'm tempted, given that we're just after the hour. We promised people a break. Is there one more question that we could take? Can you say anything, or should we?
I cannot see any, but I thought there was a hand up earlier.
Well, let's find a hand.
Sorry, I remember one of you putting their hand up in the actual chat, but I don't remember who it was. So if anybody did that, could you please do it again, unless your question has been answered? No, I can't see it at the minute.
Okay, so what I suggest we do, folks, so it's we're online for 2 hours. We want to move to a more participative sort of sharing of this with about 40 to 50 people online, which is great. We're really pleased to have you with us. It's going to be quite tough to do this, but we want to have some hands-on work with this methodology. So we're just going to take a 3-minute break now, a comfort break essentially. Please feel free to refresh your coffees, teas, or otherwise, and we'll be back in. I'm just checking my time. So we say time. So we're starting in at 10 past the hour, exactly 10 past the hour. Thank you for your attention, and see you soon. Okay, welcome back. We'll be starting again in 1 minute's time. Look forward to working with you. So thank you for sticking with us. It's great to see 46 participants online, and I'm like many people, I think, reflecting on how this is different than it would have been if we were meeting in Dubai, or how many of us would have been meeting in Dubai. But we very much wanted this to be a session about sharing and skills building with some degree of collaboration on this. Hopefully you've seen from the first hour and those illustrations sort of some theory and some conceptual material, but also lots of very concrete detail of practice. So hopefully if you are to pursue this, or if you are already pursuing it, there's been some material in the last hour that's been useful for you, giving you the confidence, some ideas to use some of these methods. But we did want there to be an opportunity to think this through in a practical reality, and that flow that I talked about at the outset, just to think through some of the decisions that you would need to make in terms of flow. So without a safety net, Karen is now going to lead us in a participatory exercise, and very much encourage your participation over the next 40 minutes or so. Karen.
Brilliant. Thank you so much. So I'm just going to keep my video on for now, but I'm probably going to need to kind of toggle between things. So I might turn that off and then just see how this works. So there should be a link to the Jamboard within the actual platform that you will, HSR platform. So it should look a little bit like the link you can maybe see here on top of my screen. So jamboard.google.com. And then there's a long link. I would urge you to please copy that link and to open up a browser window, and we will all be looking at that browser window, which is a very typical GMB activity. You're all focused on one thing. And for those of you who haven't used Jamboard before, there are different things you can do. So for example, you can draw on this board, this is an eraser, you can select different things, you can add sticky notes, you can add images, for example. I would really encourage you, as many of you as possible, to join. What I'm going to try to do is, and this is going to be very difficult, I'm hoping that some of you may be able equally to speak in the actual meeting platform if we allow that. But actually what probably would be easier is if you just add sticky notes or text or things to this Jamboard as we go along. So as Alistair said, what we're aiming to do is really guide you in thinking about how you might structure your own group model building session. And we're not going to get to the end, but it's at least to show you the kind of resources and the kind of thinking that goes into that. I've obviously picked a topic that is dear to us all at the minute. So health system responses to COVID-19. This is mainly because it's one topic I think that we can all in some way have touched upon in the last few months. But what we will need to do now for the first 10 minutes is really try and think about, okay, this is a very broad topic. What is the actual problem that we want to be focusing our group model building session on if we were to design one? What might the boundary be around that problem? And who would our client group or our participants, if you like, stakeholders that we care about, whose views we care about, who would they be? So I would say I'm going to urge you, I see a couple of you joined here. I can only see you on my screen as Anonymous Dinosaur, Python, and so on. So please, I'm sorry if I call out the wrong animal name. Use the sticky notes on the side, and maybe you have a way to formulate a problem that you might want the group model building session to focus around health systems responses to COVID-19. So anyone...
Karen, can I just ask one thing for others that might be struggling a little bit like me? So in I actually can't see the chat function on the screen at the moment, and others might have the same display as me. So where would we find it to be able to find that link, to be able to open that link?
So it should be in the discussion forum and in the Q&A, at least I think so. Julia?
Yes, in the forum, in the platform, HSR platform, you can find the chat, and also in the Q&A chat box. Yeah, you should be fine. You should be able to find the link.
I mean, regardless, you can easily, even if you just want to tell me, and I can type for you if you like. So I can equally create a sticky note in yellow. If anybody has a way to maybe formulate a problem, please shout out. I think we can unmute participants, so I'm going to let Julia do that as host. I see an anonymous capybara has joined. I'm going to give you a couple more minutes. Oh, there we go. We have some things. Balancing essential versus non-essential. Okay, that's an interesting one. I'm going to put it here. Yeah, keep going. So we're saying during COVID-19, how do we balance the essentials versus the non-essentials? Okay. Any others? There's more people joining. I'm going to give a couple more minutes for this before I move you on. Okay, there we go. Protect vulnerable groups. Let's keep going.
Can you do a post-it for me about addressing reluctance to attend primary healthcare facilities, basically? Fear of attending health centres.
Okay, addressing the fear. Okay, brilliant. Okay, so I mean, some of you can do this, which is great. So I think you see what we're doing, and this is a typical activity that you wouldn't necessarily do, for example, problem identification, but in GMBs generally, you will work a lot with sticky notes if you're doing this in person. Brilliant. Okay, so this is great. We have a couple of topics here. So what I'm going to encourage us now to think about, okay, please stop eliciting topics. Now you have a few too many. What we're going to think about is which of these really, maybe we want to amalgamate some of them into one. Maybe we want to think about, you know, one topic that might address three things. So one problem. Which one of these would you like? I'm going to suggest that you essentially just shout out. Maybe I can just put, for example, balancing, let's say, do we want to do, is the problem, how do we balance essential versus non-essential? Equally, how do we ensure that services are not interrupted? This work looks a little bit similar. Back to non-COVID diseases. We have something about availability of evidence, knowledge and skills of HR, protection. Which of these would you like to focus our group model building session on? Okay, loss of health workers, very good one. Maybe how about something around, and please stop eliciting new topics because we can keep going with that for a while. How about something around how do we protect frontline health workers and ensure we have no losses, and that kind of relates a little bit to knowledge and skills. Would that be all right for the group? Please do use the chat functions, or again, raise your hand even. I think Julia can unmute you and you can speak to me. Okay, so I'm going to put these down and I'm going to say, So again, you can focus the problem as you would like. I think the main point I'm trying to make is that you do need a little bit more of detail to be able to put down a problem. So let's say our problem that we want to focus on, or our question, is how do we protect healthcare workers during COVID-19 and ensure their health? Yes, so that we avoid losses. Would that be? Yeah.
Just their health and attendance is because it's their capacity to contribute, isn't it? That's particularly important. Yeah.
And attendance at clinics.
Yeah.
There we go. Perfect. Okay. So the second question is obviously then, how do we make that? How do we bound that topic? So do we want to look, for example, retrospectively at how early on, maybe in the COVID response, this problem might have been handled? Or do we want to look at how is it now handled? So basically, what kind of time frame or other boundary limits would we like to impose? It might be related to time, location. It might be that you actually want to take a health systems level. So for example, if this were a policy problem, we might think about what kind of occupational health policies, are there, and what kind of occupational health generally policy making is there. So again, I would urge you for 2 minutes, just stick up some sticky notes about how you would bound that. And then again, we'll try and pick a boundary that is feasible in some way and then work from that. I'm hoping you're all typing. Okay, so we bound by the type of worker. Yep, very good. Frontline. And could we be a little bit more specific there? If we say frontline, is it at, for example, primary? Is it secondary? Is it all frontline? Trying to check which animal that was. Anonymous hippo. Any other ideas on boundary? Hospital, great. Okay, so we might focus specifically on that level. Okay. Ooh. All right, I'm not quite sure why they keep appearing only in that location. During pandemic and post, around mental health, great. Okay, so when we say during pandemic, do we mean during immediate response and then longer term? So that's our time bound. So maybe from start until now, okay, within current laws, rules and regulations, worker protection, okay. Retrospective and current, perfect. Okay, so I think you see the point again, what we're trying to do, and you might obviously do this for a particular country or a particular place, is you're trying to get to a more detailed definition of the problem. So if we now said what our group model building session really focuses on is this question in relation to hospital frontline workers and their actions, if you like, during the pandemic, and then also with a long-term perspective in mind. The next question is really, who would be your clients? Who would be the people that you might want to invite to your group model building session? Who would have something to say about how we protect our frontline hospital healthcare workers?
Karen, sorry, just before you go on to that, on the boundary, I think the thing that I found most interesting and challenging in a way has been the time boundary, just before we, so here, it's clearly talking about the current situation. One would probably want to reflect on before COVID, so how have things changed in that period? But in a situation like Sierra Leone, for example, where Ebola is in many workers' memory, there's almost the longer term perspective in terms of how have you dealt with things in the past is also sometimes in play. So I'm not commending one or the other, but just to recognize that there's a choice looking at the dynamics over time, whether you choose a relatively short time frame. We once in Gaza, we did it over a 60-day conflict, 50-day conflict. But in other times, you're probably looking over a number of years of how things have changed, and just acknowledging that's a really important decision on the boundary. Sorry, Karen.
Yeah, no, that sounds great. Yeah, so I think it very much matters on how you obviously shape that and how you might think about it. I think we'll come to a little bit later. You might obviously refine the boundary depending on the kind of exercises you might think about doing. So I think your example there is quite relevant. Obviously, people who have had major outbreaks of infectious disease would have a different level of experience to draw on. Okay, so in terms of clients, I'm going to move this so that we have a bit more space down here. There we go. Yes, please move things around. Great. Okay, so clinical managers, frontline health workers, managers. Yeah, okay, so we have multiple managers. Great. We have health secretaries. Amazing. Okay, so these are all people who have something to tell you immediately about this problem. I think, again, what I would urge you to think about is, health policymakers who would be changing the way that they make decisions based upon your findings. And it is usually worth having one or two people there. There is a big challenge then, of course, about having somebody who might be more powerful, more senior in the meeting, and how you might need to navigate that within the actual group model building session. But again, it is worth it, even if it is just for them to be exposed. So I'm just going to community leaders, to be exposed to the thinking that goes on in this session and for them to take away some of the lessons that people might consider. Okay.
And just on that, Karen, sort of stretching the phenomenon, the thing that I see missing from that list is someone like cleaning staff or porters who may have an important role in terms of cleanliness.
Yeah.
And I mentioned clerks earlier on, not to forget staff that potentially provide a key function that we would not normally consult with, but are part of the team. Yeah.
Absolutely. So people who you generally might not think about, but equally are relevant. So, and I think at that point, it's very important to think again about if your boundary were a specific clinic or object, it's not that you would be planning the session, object like a specific area. You're not planning the session usually by yourself. You would have to reach out, for example, to the officer in charge of a clinic or to the manager of a hospital and genuinely just ask who might have interesting perspectives on this in your particular situation. And they would obviously come up with more people. Generally, great, community health workers as well. So generally, it really depends on the size of your actual modeling team about how many people you're then able to invite as clients. So usually, let's say you would not expect to have more than 8 to 10 people per group. And that's actually quite a tough situation to manage unless you have experience in doing that kind of facilitation, as I was saying. It's quite exhausting and you do need multiple people to be there. So again, you might have one facilitator, but then there is a note taker. Usually there's somebody who actually reflects on model building at the same time. So all of these people are needed per group. So again, bear that in mind because you don't want to have too many participants in your group model building session, but then not have enough facilitators. Okay, I'm going to move you on just because of time. Again, this is a very rushed example, and obviously if we were in person, this might have taken a lot longer.
Karen, just as you move on, just to note, I'm delighted we've now got 78 participants, which means there's probably at least 20 people that have joined us since the hour. Just to let you know that we're in the middle of a sort of a simulation exercise. We did presentations on group model building a little earlier, and you're very welcome if you contact us to get the material on the PowerPoint for that part of the presentation. And Karen is now just taking us through the steps within a group model building approach, and we're just crowdsourcing essentially how we might approach a health system response to COVID-19. So I hope you can follow what we're doing, and please feel free to both download the link to the Jamboard which we're using, which is in the chat function, and or post questions in the Q&A. Thanks, Karen.
Brilliant. Okay, so our second real issue is, let's say we've decided basically on what our problem is, we've decided on the boundary, and we've decided on the clients that we might want to invite to our group model building session. the next stage really is to structure your group model building session, but also to, as I was saying, decide on your modeling team. It's easier to decide on your modeling team, so I'm going to just leave that to you. And I think what I would like to do is just focus a little bit on the kinds of things you might want to do in the actual group model building session itself. So one resource that I can highly recommend is scripts for group model building, Scriptopedia. So in Scriptopedia, and I'm hoping that you can see this on my screen, it's just a wiki that has been created by people who use group model building mainly for system dynamics purposes. So again, be highly aware of that. We have a particular way of framing things, mainly because we care about feedback loops for good reason. But there are many scripts available here. And again, scripts are just a description of a specific activity. So for example, if you were looking to have a script that looks to just present something, like a concept model, let's say, you would click on it and then underneath it, you would find guides on, okay, what materials do you need? What inputs? What are the outputs? What are kind of roles? What are the steps? And usually most people actually will upload their materials to Scriptopedia. I found it hugely useful when I was starting in the field. I've developed some scripts since then. So again, it's quite a good way of thinking about how you're going to, what activities you really would want to put in. So for us, for our purpose, I think the easiest thing to do is really to kind of mimic that structure that we gave you at the beginning. So usually what we start with any session is an introduction. And that would be very kind of topical, and it would seek to just say, what is the purpose of the day? What are we here all to do? And after that, I'm wondering, what are the kind of things that you heard us say? What would you think would come next, basically? This is not a test, but it is slightly a test if you were listening.
While people are typing that in, Karen, just one thing just to reinforce in terms of mentioning the modeling team, which I think is useful in introductions, is whose model is this? And the argument would be that this is a model for the participants, and the modeling team is a listening team that tries to listen to what's being said and tries to present back and saying, is this what you're saying? Does this fit? And I think that dynamic is really quite important. So that the modeling team has expertise and capacities, but it's not their model. It's not an extractive process. It's very much to lead the participants, to help them to tell their story through the modeling. So I think that message is something quite important to do in the introduction. Hopefully that bought a little bit of time while I've got.
Brilliant. So we've got some rich pictures. Yes. So, and again, for those of you familiar with rich pictures, this is not something that group model building by itself came up with or uses. Obviously, people like Checkland and so on have used similar kind of methods. So the point of rich pictures usually, and we can actually go and find a script for rich pictures. Oh, well, I can give you one. Is really to try and, mapping, great. Is to try and get participants to draw something. So in our case, if we think about, let's say we have the problem of how do we protect health workers, we're talking particularly about frontline workers during the current pandemic, but also reflecting a little bit on the previous. What might we get them to draw? Let's just focus on that for a minute, and then we might think about mapping in a second. What kind of rich picture would we maybe want? Any ideas? I can give you an easy one would be if you're saying, how do we protect? Exactly. Thank you. Perfect. What does it have? Yes, that's exactly it. What would protected look like? What would be a risk? Can they draw them? Can they put them up? Can they, if you're thinking particularly over time, can they think about certain things that, for example, pre-pandemic might have been just there and now they're a risk, but actually, or things that before in previous pandemics were risk, or previous epidemics were risks and now equally are risks. So you might want to integrate an over time perspective, but generally you're right. You would want to focus on, okay, what are immediate things that come to mind? What does protected health worker look like? What does a risk look like? Something, protective measures. one thing I often do for infectious disease is to say, where is the risk high? And then get people to draw the actual place within a particular, for example, hospital, and then to draw the situation that might create risk. Perfect. Satisfied or not with protection? Yes. So again, you might, I think just remember, you have to give a very exact instruction to people, but you have to also get them to do things fast. So usually a rich picture exercise doesn't last more than 10 minutes, and it's only the first 5, perfect PPE, the first 5 minutes really that you want to be drawing. Great. I'm going to stop here with rich pictures. Another activity you might then want to do, so basically we're saying we're going to do introduction and then we move into activities more or less straight away. So one of your activities was the rich pictures. Another, I'm wondering, people who said mapping, what mapping do we mean here? Because there's different types of mapping you might want to be doing. You could be mapping trends over time, for example, which is what Aya and Seema equally were talking about. In which case, for example, you could get people to draw patterns of staff absence, which would be interesting. Perfect. Concept model elaboration. Great. So essentially, you can see the flow. You're trying to move people along by doing specific activities to get to this point of concept model elaboration. The reason we don't go straight into this, even though it is possible, is that usually it requires quite a lot of intellect. I mean, again, it's very easy for somebody to focus on one task and then to build from the next task on the previous. It's very hard usually to just say, put down a concept model on this, or tell me about things that might, affect protection of staff in a hospital. Great. So let's say you were mapping trends. You could be mapping, great. So for example, you could be mapping patterns of staff absence. You could be mapping patterns, for example, in availability, great, of specific PPE, great. You could also be mapping, so sometimes what people do, great, quality assurance trends, is to map a specific clinical pathway or a kind of pathway of patients as they might come in. So especially if we think about COVID-19, draw where the virus is. Oh, this is a good one. Maybe we need to move that. Then we're thinking about what is the pathway of people maybe through our hospital or through our particular kind of clinic, and what does that really mean for us in terms of different things we want to map, risks at specific places, who is working where, who do we need to be protecting, exactly who are the stakeholders in this. So you get the point. It's basically you can do different types of mapping as long as it gets you to identify who's at risk where and so on, and how, what kind of things might impact upon protection.
So
Great.
Karen, just to come in there, I think one really important thing about the rich pictures, it's about the flow of this activity again, from the rich pictures to those other mapping activities that you've got there. If you have rich pictures, are never easy to do. People are reluctant, they giggle, they're not quite comfortable. But the whole idea is that by getting something on the page that's not in words, it sort of depicts, it connects to, in this instance, is fear, uncertainty, the context, which then when it's on the wall, you can refer back to. Once we get to mapping and we're asking who is working what, when and where, the danger is we get a bit verbal and a bit conceptual, and we can refer back to the rich picture and say, well, hang on, there's someone you've not talked about that is depicted in this picture. There is this character here, or is this risk that you've done in the picture that you've not mentioned that yet. So that flow of the rich picture eliciting a non-verbal, broader range of issues, which you can then follow up in a more analytical way in later stages.
Yeah, exactly. And that's perfect. And so the thing that we want to be doing in this mapping is equally, we want to do variable elicitation. So you might, I'm just going to write that down. So you're starting really to think about what are the kind of, we would call them obviously factors really, that impact on how our problem is shaped. So again, how do we protect health? What are the kind of variables that really matter? And you can see you're already starting to do that. You're saying logistics, PPE matter, the staff working patterns, where, when, what do they do? How was quality assurance done previously? All of these variables, they're starting to come up naturally because you're now starting to become more analytical, and eventually you'll need to elicit a kind of long set of variables. I will warn you that actually it's quite hard, so don't go overboard. You don't want too many variables. You would want something like 15 probably, but you want them to be very specific. So for example, if you said, let's just take logistics and support. Somebody might say that in your group model building session and say, well, that impacts on how protected I am at work. And I would expect most facilitators to then really prompt, okay, what do you mean by that? Is it about the availability? Is it about the supply chain? Is it about when the delivery of PPE comes to the facility? Is it about the actual quantification of PPE we might need? You really need to drill down, because unless you do that, your model will remain highly conceptual and not be operational enough really for people to engage with, or for you to then design an intervention around if that's the eventual goal that you're going towards. So perfect. These are the general activities that you would do. And again, obviously there are activities, remember, beyond your group model building session itself. I'm going to move us on to the next board just because we have 20 minutes left. So let's say you've decided you have obviously your problem definition, the boundaries, the client groups. You now know what you're going to be doing with them. And usually it really very much helps, similar to what Aya has shown you. You would have a kind of facilitator's guide, you train your facilitators on it, and they would have to do this. After that, what might help you, and this is what Zainab pointed out in her presentation, is a seed model. And really, what is a seed model? It's a couple of variables, 2 to 3, that you might already start to put together because you have pre-existing knowledge of the field, because you have pre-existing knowledge of the problem, and you just offer that to your participants as a starting point. Mm-hmm. So, okay, sorry, something happened with my audio. Again, if you think that this is helpful for very complex topics, it usually is really helpful. Then you would want to start really building one prior to your group model building session and then presenting it to your participants. So I'm just going to get you to think a little bit, what might be, let's say, 2 or 3 key variables from what you've had, for example, said before, very specific variables. Can you try and put them on the board? And then what we'll try to do is just link them up so you can see what a seed model might look like.
And the hint we always give is that this is a variable, so it's something that can go up or down. So it's helpful to word it in that way, that this is something that could increase or could decrease.
Okay, just giving you a couple of seconds. Perfect, that's a very good one. It usually helps for some particular problem specifically. So the way that you, for example, perfect, risk of infection, great. Any more? Skilled, great. Whoever wrote skilled, I'm going to pick you. You'll have to be a bit more specific. So this is it. It's like, what do you mean? The skill level of the health worker? And if so, then let's phrase it like that. The awareness of the healthcare worker, perfect. So you see what we mean. It's something that can increase, decrease, but equally has a very specific point. And again, so for example, for awareness.
Indicator?
Yeah, similar to an indicator. Yeah, that would be very, yeah.
Okay.
There we go. Infection control measures. Okay, so you see the point. You have all of these. And again, this is a very kind of raw way of us doing it. What equally might help you, okay, that's a very vague one. I'm sorry, I'm going to pick on people. Whoever puts, so again, you don't want very vague things. So as a facilitator, if you're doing this and you pick, for example, factors related, that's almost like an encompassing variable of everything out there under the sun. You want to drill down. What does the participant mean? What exactly are the factors? Can they go? Great. Financial resources. I would say available where, but okay. You see my point. You have to constantly be really drilling down, and that's why the group really needs to be kept small. Perfect. Manager involvement.
And to make the model work, skilled health workers, we probably want attendance of those workers, don't we? That would probably is what I would intervene if we were doing this in real life.
So, but those two are different concepts. So you would have skill level of health worker and then attendance of health worker. Protocols, perfect. Okay, so you see the point. So let's now start very stepwise. So what you would usually do with your participants, protocols, similar to protocols, is you would pick one variable that's maybe easy, let's say risk of infection with COVID, and say, okay, what other variable can I link to the risk of infection with COVID? So for example, what increases my risk of infection with COVID? And then you would draw a causal line if you like. So if I had, I'll try to do it first. If we have good availability of PPE, my risk of infection with COVID would be low. So we would draw an arrow and we would put a minus underneath it, because the higher the availability of PPE, we assume, other things being equal, our risk of infection would be lower. Great. If we had awareness of healthcare workers, I'm guessing 2 COVID risks, perfect. You see the point. So that's what you need to start. Can I get you to do the arrow bit and the polarity? Sorry, I'm being picky because that's the point. You want people to start drawing themselves. You want them, if you were doing this on the day, to put down arrows, to put down polarities, but you also want to really get them exactly to think about, well, what does that actually say? Great. Okay, so you see the point. Yes, you're starting to put together a lot of these. So you already here have too many variables for this to really, I don't know what RCCE means. I'm very sorry, that's probably me. But you're starting to put together links between different variables. Great, so here's a good one. Manager involvement, I'm assuming in decision making, would affect both availability of PPE and infection control measures. And if we have both of these, then our risk to infection might be lower. So that's great. So for example, now, if I were facilitating, I would ask you, well, what actually makes the manager be more involved or less involved? Great, thank you.
I think the other thing that this is a great illustration of, Karen, is that we would, as the modeling team, challenge some of these or just ask for clarification of it. Does that directly go to that, or is that the link? Because it's not the first person to put an arrow on a page that determines it. This is a proposal, a hypothesis, which we're then getting the rest of the group to review. And so this is a really powerful source of dialogue amongst the group to say, is that the direction, the flow, or is there another factor that influences that? And it's a very concrete way of having very focused discussions on people's perceptions of influence.
Yes, absolutely. And that's the thing that you were emphasizing as well earlier. You want to be negotiating a narrative. And it's when we said, I think Zaina, my colleague, mentioned that we needed to have agreement. We're not necessarily talking about agreement of the same pathway. So what often happens is you'll have people completely disagree. So a very good example might be, some people usually always say financial resources, if we had them, everything else would be solved. But it's very clear here, for example, financial resources is linked to one thing, but not to 5. So even if we increase that, even if this is a really important factor, there's probably 4 or 5 other things that we need to be working on. So you need to negotiate carefully with your participants. Yes, we hear your view. Yes, absolutely, we might draw a link, but we don't necessarily have to all agree on that link. It's okay for us, for the note taker, for example, to note the group has disagreements. That's what the note taker is there for them to feed back later on. Great, okay. So you get the point about this. I was just going to say we probably stop here, because what you would do in practice is you obviously work on a small model, this is already too big, I'm warning you. And what you would do is you would provide that to participants and say, now you add some variables, you negotiate some arrows, and then, like Alistair says, we would as facilitators intervene and work with the groups to develop more of a concept model. So I was just going to leave 10 minutes just for general Q&A because there might be other questions that people have. I'm going to leave this on the Jamboard for maybe another 1 minute or so, but then I think we might go back to the general kind of HSR format.
I think that's a good idea. And just to say, I think this example works really well to talk about that idea of refinement of the model. You know, very quickly you have hypotheses going in there and you really want to encourage that, but then you want to be able to review and say, well, actually, is there another factor here, or is that really the direction of the influence? And working with the team over the duration of the GMB and even after the GMB to validate some of the links. You can see how quickly it gets messy, but it's a useful messiness. But there does need to then be a challenge to some of that causal loop analysis that's beginning to emerge.
Okay, brilliant. I'm going to close the Jamboard. Well, actually, I'm not going to close. There's another board here that I've left up for reflections, for example, if there are things that you might want to put on, or equally questions. Actually, we can use this for questions as well if you want. I'm going to ask them.
I'm delighted that 75 people have stayed with us. That's great. So for some, you will have missed earlier on the presentations. I'm going to just chat quickly to Julia just to say, as we close, perhaps we can give a link or a connection just where people can get hold of the presentations that we shared earlier, just to give you a flag for that, Julia. But now we've got about 10 minutes. And I think we can, anyone that's on Jamboard can post reflections there. I think we're probably brave enough now, if there are people who would like to make a verbal contribution and unmute themselves, I think we could probably handle that, couldn't we, Karen?
Yeah, absolutely, yes.
I'm hoping. So yes, if you don't all speak at once. But very happy for any comments or reflections, particularly for anyone that's used this method or is intrigued by it. Then let's just use the last few minutes in whatever way is useful to yourselves as participants.
Just to say, I'm not able to monitor the Q&A, so if one of you just checks that, because maybe there's questions coming up there. Equally very happy to. Okay, here we go. Oh, no, I'm on the wrong. Sorry. Do you experience difficulties explaining or getting participants familiar with types? Yes, absolutely. So, and this is actually a good example of, it really depends.
Can you read the question again, Karen? I can see it in the Q&A, but this is Harry's question, but you just want to read it so others understand.
So do you experience, so I'm guessing we as a modeling group, team, do you experience difficulties explaining or getting participants familiar with types of complex interrelations? So what is a dependency, a reciprocal relation, causal, and so on? Do you want to, or shall I try?
I'll have a go. I was taught, and it generally works, that you can't allow reciprocal relations, because as soon as you get things just going in both directions, it doesn't really help an understanding of flow. So usually in that instance would say there may be a loop here, but rather than just the A affects B and B affects A, is there some other factor C that completes that loop and connection? And it's really only if it's a closed, it's just two variable thing, you can't really change it. It's only when you find a sort of a pathway that feeds back from B back to A through C that you can really then begin to say, well, we could perhaps change that dynamic. So that's a quite common thing, that people basically want to say everything's linked to everything, which indirectly it probably is. But one, in exactly reinforcing what Karen was saying, being very, very concrete to say, well, if you needed to impact that, what would change this? Could it go up or down? And being as concrete as possible can help people, I think, work their way through those complexities.
Yeah, I would agree. I think there is a lot of work it depends on how much time you have with your participants. So there have definitely been group model building sessions where I have prompted for example, an hour about, is this really causal? Is this the way it should be going? Are there different loops here? But if I'm stuck for time, again, this is why it's so important that you have a note taker. When people tell you a story, they might just draw one arrow, but actually within their story, there's 3 variables that they've mentioned. So this is the real benefit of having somebody else there to pick up on things and to really say, don't worry about it. That arrow might be drawn wrong. I've got it. I've already noted that down. And yeah. Okay, I'm just picking some other questions. Why do we have to limit variables? To be honest, you do not, but I'll just give you an example. This is what it looks like with how many, maybe 12 variables or something. Now imagine this with more than 25. How many links and interrelations would you really have? That's why generally you want to be limiting. And again, that's why it's important to define your problem early on and what the limits are. So for example, if you said there are certain things that we definitely will not touch, then you might move your participants away from that and say, we acknowledge these variables exist. We acknowledge that someplace they do influence everything, but we're not going to put them in the model because that's too much complexity. So again, it also helps because sometimes what people will do, and there is a tendency, especially if you invite very specific levels of expertise, for example, in a system, to develop sub-models. So there might be a little sub-model on financing, and there might be a little sub-model on HR management. You don't want that. You want a commonly negotiated model. So you want to bring people together and to really only keep those variables that they can think about together. Alistair, I don't know if you have any. Oh,
I just wanted to comment on the question about interesting software to engage with participants. It really is. I have to say, to date, most of the GMBs that I've been involved in have failed to do what I thought might be possible. I know some do, which is actually interactively work with a Venn-Sim diagram, moving it around very, very fluently and actively with the group and saying, oh, there's a new link here. It's just very complex to do that. So what we've often done is transform, usually during a coffee break or a lunch break, the post-it models and the loops to show then here's a representation of that on Venn-Sim, and people are usually quite excited that it's transferable, and then do a little bit of editing of that and to show how it can be edited, and we can move a link and we can move things quite readily. But actually live facilitation of the whole discussion on the software, I think is very difficult, and I think that's right, Karen. I don't think we've ever really managed to do that live, which I know some research groups do, and is clearly potentially quite powerful.
Just picking a couple more questions or comments. So one on resource intensity and high-level buy-in. Absolutely. I think that's the one thing that is very particular. It's very comparative to other methods. It might be faster, but it definitely requires more concerted time. It's at specific points in time. But having
I'll pick up that. Sorry, go on, Karen.
No, I was going to say, I think most of the times when we've done this, actually people have enjoyed it. I mean, they've left exhausted because they've built a model that's actually quite tough to build, but they have definitely enjoyed it. And most of the time, actually, I think we get comments about, we would like to do this again in a different way. So I think that's interesting as well to note.
I was just going to pick up that question at the bottom about the variable limits and common number of variables that drive or responsible. The interrelationship diagram exercise, which is basically putting the key variables in a ring and then drawing lines between them, and then looking at the cells, the variables at the post-its that have lots of incoming or outgoing lines, that is quite a useful way of filtering out and saying, look, clearly then this is a key driver, a key factor. Let's put it in the model and develop it that way. So in terms of the sort of editing processes, the refining process that Karen was referring to, that can be quite useful to identify some of the key drivers. Although it's also true that part of the whole process is about identifying resources, as Karen said, it's often seen as, oh, that's the key driver, but there are often other things you wouldn't anticipate that end up being implicated on quite a lot of pathways that are more tractable potentially to address.
Mm-hmm. Just a last question over on, do you have any training suggestions on methods or to understand them deeper? There is, I think, the last slide of the presentation, and maybe I'll stop sharing my screen because maybe that, but basically the last slide had some suggestions from us on key readings. There's some guidance as well that we've obviously put together as a group, but equally I would just recommend going through those. They're the key kind of readings that I tried to select. Oh, perfect.
Thanks ever so much, Karen. Can I just, we're a minute out, I think, or 2 minutes out. For that, I really appreciate, it's great to have 70 people with us after 2 hours. I think, as I say, there were about 40 to 50 people after 1 hour. So a number of you will have joined and not seen the presentations. I don't know if Julia knows a way that we can share a link, or what most efficient ways. Obviously, we're happy to share those presentations. I actually think if you're registered, you should be able to get onto this. Sorry, I'm busking actually what the best solution is. Yeah. But Karen or Julia, can you suggest what would be the best way for people who've missed the live presentations to access the presentations earlier?
I think you can actually review the entire presentation, so you should be able to do that at least. Maybe not the participatory elements, but certainly the beginning should be recorded, and you'd be able to view that.
It's not very easy to access.
It's not very easy to access, you're saying?
Yes, because I tried it a lot, yeah.
In which case,
if it could be emailed to us, that would be fine, since we have our email addresses.
Okay, we can try that. I'm guessing we might have to ask HSR, but yeah. Yeah,
thank you.
If in doubt, you can find us at that Research Unit on Health and Fragility, or RUHF. If you send us an email, we'll obviously be very welcome to share the presentations.
Okay, can you share your email so that I can do that?
Could you do that on the Jamboard, Julia or Karen? Would that be the quickest thing, just to put the RUF email up? Oh, well, so that's the...
If you can share your email, we copy it. Understand?
Can you put the Jamboard up, Karen, and just put the address on it? Would that be the quickest thing? And just put ruhf@qmu.ac.uk?
You're too fast.
Sorry, no, I was prompting my colleague to do it. Karen, can you get the Jamboard back?
Okay, let me try.
Sorry, I'm trying, but somebody else is screen sharing, so I can't actually do it.
Okay, well,
Julia, I've just put it on the Jamboard, so you can just...
Anyway, it's RUHF, which is Research Unit on Health and Fragility.
Karen Diacono.
Yeah, you can send it to Karen, or RUHF at qmu.ac.uk.
Karen at what?
So I'll send it to, actually, can I just put it in the, I'll put my email in the chat box. Let me see if that works.
So thanks everyone for your participation. We would have loved to have been with you in Dubai, where we could have done this with abandon around tables with sticky notes and post-its. But really, thank you for your engagement. We do hope you found it useful as we shared our experiences of exploring with these methods. And please stay in contact with us. And we do like to hear anything of your work with these methods and to share, to develop a community exploring participatory work of this nature and modelling work of this nature. So we'll shortly, I think, be terminated. So thanks so much for your time. Really appreciate it. It's your engagement. Thanks so much to Karen, Aya and Zaina for their contributions earlier. And thanks for some excellent questions and engagement over the 2 hours. So really appreciate your engagement. Hope you found it useful, and say please keep in touch.
Thank you very much.